Secretary of State, our work has highlighted significant variation in the quality of general practice. How will what you've announced today contribute to improving the quality of general practice?
Well, actually, we have significant variation in quality throughout the NHS, not just in general practice. I mean, if you look at the highest risk emergency surgery, there's a variation in the mortality rates of between 20 and 40%, which is a huge variation when lives are at stake. I'm sure that's true for general practice as well. And I think the best way of dealing with those issues is not through mandating things from the centre, but by transparency. And so what I've announced this week, which is Ofsted-style ratings of GP practices, will mean that the public will for the first time get an independent view as to how good their local practice is. And I think that will focus attention both on the areas of weakness, but also I think just as important on where we have best practice. Because I think what we've learned from the school sector is that very often the key to turning around failing schools are the schools down the road that are outstanding. And that's what I hope will happen with general practice.
The government's response to the Francis report identified the need for strong clinical leadership. Our work suggests that many clinicians are reluctant to go over to what they see as the dark side. How do we encourage clinicians to take responsibility for leadership of the system?
Well, we absolutely need to do that because there are lots and lots of examples of brilliant managers who have a clinical background, and that helps them to be the brilliant managers that they are. But I think one of the things that we can really do that will make this more attractive to clinicians is by having independent Ofsted-style assessment of hospitals. We will for the first time be recognising independently where the outstanding leadership lies. We had the old star rating system, but that was really a performance management tool as used by the Department of Health at the time. And you could get star ratings by meeting your 18-week waiting time targets and your 4-hour A&E targets. This will be the first time someone is taking a holistic view of a hospital. It'll be peer review, and they will say that the top hospitals are outstanding, world class. And I think that that will give huge professional status to the people leading those trusts. And I think that will deal with the problem we have at the moment, which is that we just don't have enough recognition of some of the truly world-class leaders that we have in our system.
So what's going to encourage doctors to take on roles in less good hospitals?
Well, I'm sorry to make yet another education comparison, but 25 years ago, before we had Ofsted, the highest status heads were the head of Eton or of Winchester or some of the big public schools. Now the highest status heads are the people who've been into an inner city comprehensive and turned it from a failing school into an outstanding school. So the way that we attract managers and clinicians is by having an objective way of measuring the improvement of a hospital in a way that the public understands and the NHS understands. And I think that will be the way that we can create a culture of continuous improvement, continuous driving up of standards.
You've recently spent some time on the front line getting first-hand experience in hospitals. What have you learnt from this in terms of putting patients first?
My goodness me, what a question. I mean, I started this a couple of months ago. It's part of my department's response to the Francis report that we should all get out onto the front line. And my only regret is that I didn't start doing it the day I became Health Secretary, because I've learned so much. I've washed so many beds in A&E departments. This morning I was on the reception of an A&E department, actually seeing members of the public logging people in as they came in. I think what I've realised, something perhaps I suspected in theory but I hadn't seen firsthand, is how many of the processes that have apparently been set up to improve patient care actually take frontline staff away from patients. So a nurse working in one A&E department I went to said that if you're on the afternoon shift, because that's when they're trying to admit patients to the hospital, she would spend 2/3 of her time filling out paperwork and not being with patients. 2/3 of a nurse's time. I mean, it's a big burden, and what we need to do is to have structures and systems that free up time of people on the front line to do what they came into the profession to do, and that is to be at the bedside.
So I can see the energy from you, from the visits that you've had. How is the learning from that going to be shared?
Well, it's not just me. I mean, you know, every single civil servant in my department, if they want promotion, is going to be spending a month on the front line every year. Because I think we want what's happening on the front line to infuse every single policy decision that's made. And so I want to send a signal to NHS staff that you know, we know how hard they're working, we know the pressure they're under. I don't think NHS staff have ever worked harder. But I don't want this to be a kind of media stunt. I want it to be, you know, something that genuinely informs every single decision that I take as Health Secretary.
73% of NHS professionals who answered our leadership survey said not enough priority was being given to the quality of care in the NHS. What single change would do most to make patient-centred leadership a reality?
It's always tempting to say that there's a single answer, and there very rarely is. But first of all, I agree. I think that is the issue. And I don't think it's the fault of NHS staff either. I think we've created structures where too often the system is more important than the individual. And that wasn't why the NHS was set up. In fact, the opposite. The NHS was set up because we want to value every single citizen in our country as an individual, whether they're rich or poor, or north or south, or young or old. And we've lost that in some parts of the NHS because of the structures and systems we've created. So I think the single change we need, if I can put it this way, is we need to make sure that the definition of success for a hospital is a hospital that puts patients first. And you know, there are going to be lots of different things, the waiting time targets, the governance arrangements, the friends and family, the safety, the clinical outcomes. These all really matter, but in the end we need structures where nowhere is described as a successful hospital unless it's somewhere that puts patients first. And I think we can get there. I think the new inspection regime will help. I think the way the NHS is engaged with the Francis report is immensely encouraging. We could have stepped back and said what happened at mid-staffs is something that was just uniquely awful about one hospital. You know, a few bad apples as managers and a few bad nurses or whatever. We haven't done that. There's been a lot of soul searching and a lot of honesty, and I think that really bodes well.
So do you think we need a different type of leadership in NHS organisations?
Well, we could always do with more good leaders. And indeed, if you look at mid-staffs, the chief executive at mid-staffs at the time of the problems that we're now all thinking about, that, well, apparently only 2 people who applied for his job and he was the better of the 2. So you always want to attract more good leaders. But I don't think it's about so much about the people as about how we define success. So people who run hospitals are competitive people who want to do well. It's how we define what the definition of success is. And if that is about having somewhere that's patient-centred, somewhere that meets its targets, but not at any cost, someone that meets its targets by doing the right things and not by cutting corners, and that's the change that we need.
Our Time to Think Differently programme argues that fundamental change is needed in the healthcare system to meet the challenges of the future. What do you think needs to change?
Well, lots of things need to change, but let me just give you 2 that I think are worth thinking about. I think the first is that we need to embrace all the opportunities of the technology revolution, because that will free up time for nurses to spend more time with patients. It will mean that paramedics know that someone is a diabetic before they pick them up on a 999 call. It should eliminate wrongly administering medicine. The second change is we need to fundamentally rethink primary care and the role of prevention, but also I think the role of the primary care system as the gateway to an integrated care pathway that can give people the care they need at home better, so that they don't always need to go to hospital, which particularly for frail elderly, if you've got dementia, an A&E department can be a very confusing place. And I was reading an email just this week from someone who said that when his mother was admitted to A&E, that was when her mild dementia took a real turn for the worse. And so a proper understanding of primary care. And let me just finish on an optimistic note. This is something we can do in the NHS. Because we have a National Health Service, if we decide this is what we need to do, we can do it much more easily than in a fragmented system. And so I'm full of optimism that actually this is a bridge we can cross.
Jeremy, thank you very much.
Thank you.